At the moment, right today, there are 448 people in hospital across Australia with this problem. There are 96 people in intensive care and 35 of those are on ventilators. I would stress that some of those people that are in intensive care are relatively young, so in their 30s. So this is not just an old person's disease. This is something that can affect the whole of our population, and that's why we need the whole of the population to continue to take this seriously. Of those 5,795 cases, around 8% of those are now what we call local transmission without a definite link to either a confirmed case or someone that's come back from international travel. So again, a relatively small proportion, but that's the component of the epidemic that we are most concerned about as we go forward. Our low mortality rate and our low percentage positive in our testing shows me that we are actually finding people early in this disease, isolating them and breaking those chains of transmission that spread through the whole population. So these are very encouraging signs indeed. I just want to talk a little bit about how we know where we are and going forward, and what are the ways we'll be looking at the infection going forward to make decisions about what we should do next. There's various sources. Modelling will be discussed at National Cabinet tomorrow, as was forecast by the Prime Minister on Friday. That is one of the sources we use. We use the daily counts of cases and laboratory testing, as I've demonstrated today. But there are other things. I really want to encourage Australians today to think about joining our flu tracking network. And that is a network of over 60,000 Australians now and 30,000 in New Zealand as well, who every week take about 10 or 15 seconds to contribute their data. It's like a citizen science, if you like, about how they're feeling in terms of respiratory symptoms. It's very quick, it's on the web. When you join up, you're asked some small details about where you live and so forth, just so we can have a tracking across Australia and a map of hotspots of people with respiratory disease. This has been running for some years now out of the University of Newcastle and Hunter New England Health Service, but covers the whole of Australia. So I'd really encourage people to take this on board and to take this opportunity. flutracking.net/join. Please do it today. Okay, I'm happy to take questions.
Just on the mental health side of this, are you concerned at all about the expected rise in suicide and how that's also going to impact the hospital and healthcare system?
Certainly we are very concerned about all health matters in Australia. We're the health department, we're not just the COVID department, but the COVID issue is actually our main concern at the moment, and we certainly recognise many of the social distancing elements that have come into play in the last few weeks in Australia has indeed, could indeed have on different side effects, different unintended consequences. And the issue of mental health is a very important one. And I've said here before, and I'll say it again, that social distancing does not mean you don't remain connected. We need to remain connected, and people find different ways of doing that with health services if you have a mental health issue, with friends and family, and with society in general. It's just a different way of doing it.
So does the potential rise in suicides concern you?
Of course, if there was a potential for suicide rising, it would concern me, yes.
Dr. Kelly, in the United States, the Centre for Disease Control has essentially conceded that not all the deaths that are corona-related may be recorded because there's no laboratory testing before a person is pronounced deceased. It's not counted. Is that something we're seeing in Australia as well? And is there a potential that a lot of these deaths are actually underreported due to coronavirus?
I don't believe that we're in that same situation as the United States at the moment. We must remember, it's a terrible and tragic scenes we're seeing in many parts of the US now in terms of the sheer numbers of cases that they're dealing with. In total, the ones in hospital, the ones in intensive care, and many, many deaths. keeping up with that would be extraordinarily difficult. We're not in that situation in Australia. The things that we've done in the past weeks to prevent ourselves going into that situation have been successful up to now, and we have to redouble our efforts to make sure that doesn't happen into the future. In terms of deaths being missed, of course that's a possibility, but we do know that we are being very clear and careful for anyone who is seeking hospitalisation for pneumonia, severe pneumonia, without any other obvious cause, that they are being tested. If they were to die and it was in hospital, we would know that.
Professor Kelly, when you talked earlier about the statistics, you were talking about a group of people who were in their 30s who are in intensive care units across the country at the moment. Can you tell us any more about those cases? Is there any commonality between them? Do they have any underlying conditions? Were they from overseas? Do they acquire them here? What can you tell us?
So I won't go into details, of course, about specific cases, but I will say this, that those relatively young people, young compared with me, are indeed don't have risk factors, and so that's an important point. This is a disease which mostly is mild, but in some occasions we have seen and will continue to see people with severe disease. Now, most of those are the more vulnerable people in our society. For example, older people, those with chronic illnesses. But as has been seen around the world so far, the more cases you get, the more likely it is that you will find people without any vulnerability to start with, and relatively young people having this disease very severely. And this is a wake-up call for all of us.
Dr. Kelly, what advice are you giving to the National Cabinet on strategies to lift social isolation measures as the new daily infection rates move towards zero? Do you think it's viable to reopen parts of the economy before daily infection rates reach zero?
So this is a very important component. We've really concentrated on putting the foot on the brake. The next obvious question is when the brake could be released. These would be difficult discussions they would be important discussions with the National Cabinet and through them to the community about the pros and cons of doing that. But certainly there are some elements to those parameters which would be similar to the ones that we were looking at in relation to putting the brake on, as it were. So how prepared are we for an increase in cases has been part of that. So our healthcare system, our supplies, our training, our staff and surge capacity within the workforce is a component. I think we can also look at those particular measures that have been brought into play as to which are the ones that could be removed early. You need to look at how that might affect the curve, and we're getting more information every day in relation to that, partly from the modelling elements, but also from the data we're collecting every day. And what effect would that have on our society in terms of the benefits of that? But I would say that people have been so far extraordinarily willing and able to change the way that are living in Australia, and I think that will come into play for some of those processes as well. I think another really crucial component is about the vaccine, which we still don't know when that may be available, but as we get more information about that in the coming days, weeks and months, that will also help us with our decision making.
Professor, the areas in Sydney in particular that have had major clusters or outbreaks around the northern beaches and Bondi, which were areas where people maybe struggle to comply with the social distancing restrictions initially. How much do you think that failure to comply with that distancing can be attributed to the spike in cases in those areas? But given they're also quite densely populated as well, is it just the case that by virtue of people doing their half hour of exercise with one other person that they're already going to be more likely to come into contact with larger groups of people?
Yeah, so the question about how local transmission takes place is a complex one, and I'm not sure I can answer that for every particular place, but certainly where people are more likely to be in shared housing, for example, where housing is more densely, where the population is more dense, and for the suburbs that you're mentioning, thinking about those other issues of health, we're very much encouraged in normal times, people going to the beach and exercising, and now we're looking to decrease that. So there is a range of issues there in terms of why local transmission may have started. The other one I'd say is that a lot of people coming back from overseas into those areas in a relatively affluent area, it would be another component of that. But I certainly don't want to get into the blame game in relation to how local transmission has started. The much more key element is how to stop it.
Professor Kelly, the department has started publishing recovery rates now as a national figure. Could you just outline why that's happening and why it's important to keep track of that?
So I think it is important. Firstly, it really reinforces that message, which is the true one, that most people who get this disease do recover. And so early on, when we just had a few cases, you'll remember, it seems ages ago, but those first cases from Wuhan and the ones from the Diamond Princess, we had a lot more time and energy, I would say, to really examine that, and people were getting clearance tests and so forth, and so we were able to very accurately say, well, this one has recovered and now this one has recovered. As we've had the higher numbers of cases, that has become more difficult, and we've had to actually use our laboratory testing for diagnosis rather than for clearance. And so during these last few weeks, we haven't concentrated on that, but I think it's important to get that message back, and we will be reporting that on a daily basis from now on.
The growth of the virus was quite high, sort of 12 to 14 days ago, 25 to 30%. Are we expecting a bit of a peak in potential deaths? That's coming up because, of course, it takes quite some time for people to get quite severely ill. And currently, what's the update on the prediction for the peak of this disease?
So we seem to have successfully flattened the curve at the moment, and so whether we indeed will get a peak is hard to know. Maybe we're there already. I don't believe so, but we will continue to get cases over the next period. In terms of deaths, yes, there is a delay between cases and deaths. Unfortunately, people tend to get sicker in their second week, the ones that get very severe disease, and so there is a small delay related to that. But we're not going to see a lot of deaths from a few weeks ago at this stage. So it's really that second.
And just to be clear on that period you were talking about regarding the peak, what is this period? A month, 2, 3? You said over this next period we'll be seeing a few more cases. Can you give me an idea of actually what that means? Yeah,
well, I mean, we're continuing to see around about the same number of cases each day, a little bit less, but we're going to continue to see cases. The peak in terms of the daily cases indeed was last week or the week before at the moment. Whether that's the final peak, I can't really say at this stage. It's speculation.
Professor, the states have expanded testing criteria. Are you expecting, do we have enough testing to sustain that? And are you expecting that to reflect more accurately the level of community transmission?
Yes, so states have started to loosen their testing regimes to a certain extent, or to expand them, and that's appropriate. You'll remember that the original case definition very much relied on travel history from overseas and from various countries, first of all, that were seen as high risk, and then to any country internationally. But now that we've essentially closed the borders to a great extent, those numbers are getting much less, and so it's very appropriate now to look at other ways we can find cases in the community. I think this very much relates also to that local transmission component, and so that will be part of it. Many states are also looking to increase surveillance through their fever clinics in emergency departments with people with pneumonia of no other known cause, as well as some high-risk settings. And with that, we'll get a bigger picture of who is positive in the community.
Dr. Kelly, earlier you mentioned shared housing and some of the risks there. Here in the ACT, we've seen an example of recruits who live in residential accommodation, caught partying over the weekend. Is that something you have a bit of sympathy for? If these people are already living in close quarters, what's wrong with them socialising, or should they not be doing it?
I think we've all got to take those messages on board. We're all part of the solution here, and so people that are in shared housing, that's already a higher risk. So shared housing, as in a barracks, for example, or a boarding school, or even a prison, cruise ships, as we've seen. People in close quarters doesn't mean they have to be close all the time, and I would certainly encourage them to consider keeping apart as much as possible, even within those close quarters, and certainly when they're outside.
Professor, the US Centre for Disease Control has recommended that Americans wear cloth masks when they go outside. Is that a good option for Australians that are worried about contracting the virus and who don't want to buy medical grade masks that are needed for our doctors?
So, so a couple of points there. Certainly the medical grade masks, we really want to reserve them for our healthcare workers, our aged care workers, our disability workers, people on the front line who are there to care for all of us, but particularly if we have this COVID-19 problem. So please don't wear those masks. Leave them for the people that really need them. In terms of cloth masks, yes, I'm aware of the CDC advice. The US is in a very different situation in terms of the numbers of cases in the community, and so there are two reasons really to wear a mask. One is if you're sick, you have it on to protect others, and that may have a role. In terms of protecting yourself from others, that may give us a false sense of security. And so our view at the moment, at least, and we're certainly looking at all of these international sources and our own expert advice on this, but at the moment we're not advising people to wear masks in the general public. Maybe one last question.
I have one more. Is the AHPBC looking at the situation in hospitals? We've had a couple of cases of the Alfred and Westmead, and overseas it's become a much bigger problem with outbreaks in hospitals. What advice are you giving on how to better prevent that from happening?
We certainly are aware of those matters, and we want to absolutely make sure our healthcare workers are protected, and that the infection control practices in our hospitals and all healthcare settings are the best we can get. This is to protect our healthcare workforce, but also the vulnerable patients that they are looking after. And so we're aware of those things. We are looking very closely at those few clusters around Australia, including to see whether indeed for those healthcare workers it was likely that they became exposed in the workplace or indeed in the general community. So, of course, we are all members of a community. There is COVID-19 in the community. We are at risk in that community, and it's not necessarily related to their healthcare giving. But even so, making sure that personal protective equipment is correctly used at the right time, hygiene practices, all of that is very important.
Should healthcare workers get free parking if they work in a hospital?
Yes, I've heard about free parking, and also what was the other one? Oh yes, free mobile phone plans. Look, I think that healthcare workers are a very important component of the community, but we're all making sacrifices. Many people are out of work, and so I think we need to take these matters into account and have a fair and equitable approach to these matters going forward. Thanks very much.